ready to rock and roll.
I think so. Is everyone on board to get started?
Yeah, I'll keep admitting everybody into the room, but just firstly,
well, hello everyone.
Just firstly, thanks David for taking the time today to do the presentation. I know you're really busy. It's always well received, though. Your commitment to continual education in the medico-legal world is much appreciated. I know we were reflecting this morning on some of the international there's not any boundaries to understanding the what constitutes pre-existing conditions in different jurisdictions around the world, but I know your insights will be not just interesting but very important to a lot of people that are on today. And with your permission, at the end of today, we will distribute the presentation. We also are recording today. An edited version will be sent to you, and if with your permission, we could distribute that to the people that request it, that would be great as well, but only, of course, with your permission.
Yeah, look, no problem at all, and happy to help out wherever I can with that. So if we're all happy, without further ado, we'll proceed. Yep. So thank you for that introduction. I'm in Brisbane, folks, at Brisbane Orthopaedic and Sports Medicine Centre, and I just a little bit about me. If you haven't come across me before, I've been in private practice for 21 years, and prior to that in the public system for quite a while. And I've been doing medico-legal reporting right from the outset. I've had a number of other positions, but look, personally, one thing that I think is important, and it has been a trend that has become more of a working best practice, I guess, of medico-legal reporting, was a swing back in probably the last 5 years, particularly, to having clinical operating surgeons engaged in medico-legal reporting, because, and I still very much try to keep, if I wanted to do just medico-legal reporting all day, every day, I could. There's enough to do that, but I don't think that that's in the best interests of anyone, because you need to be up to speed with what is actually happening. And it's like all of your own industries, be that insurance or legal or within the QComp or other work cover specters, there's always ongoing changes on the ground. And so I think it's important to keep across those so that that filters into your medico-legal reporting. Previously, you know, the adage of hawks and doves, there would be, I remember 20 or 30 years ago, you could request the type of report that you wanted, and there would be guys who would, no matter what the circumstances, are going to give a favourable report to the plaintiff or the alternative. And so, whilst there is advantages in predictable reporting and understanding, I understand that there's a product or an outcome that is desirable and reliable. I think conflicts of interest need to be are something that we all need to be aware of, and that there needs to be transparency in the process. And I think that benefits every party. And ultimately, you know, we all need to be aware of the costs of to everyone of going to court, and the costs and workflow of having very good and decent reports which give answers without necessarily dragging cases on. So I'm not particularly familiar, nor need to be, of the cost variables between the two, but I'm aware that all of these things play into the outcome of work cover and other litigation cases. So one of the main things that I wanted to talk about today was one of the areas that when I receive a report is one that's the most confusing, I believe, and not just, it can be from this end as well, but I'd like to take you through my process of, which I think is fairly mainstream, of trying to dissect out what is a pre-existing condition and what is an acute injury. And certainly from the point of view of employers, this is the one that they really struggle with. And so pre-existing conditions can be broken down into congenital conditions and familial conditions and previous injuries. And I'll go through all of these things individually. And acute injuries might be, excuse me, a singular injury or multiple singular injuries, or the one which again is contentious is a repetitive, repetitive strain injury, so to speak. My method of evaluation is that if there's a brief, I read it. That's obvious. When when there are previous opinions, it's very interesting to read and correlate those reports. And I do all of this before I write my report. I think it's important to do that because it does set up. I think one way of thinking is that don't be influenced by those previous reports. Just do whatever, just get your opinion first. And I think you can do both. I used to not read the brief prior to seeing the patient because I didn't want to be influenced. But I think it actually is better. I don't feel that I'm influenced at all, but I think it's better to get an assessment to see whether there is discrepancy if there's been previous reports. And I sort of summarise that in my mind and then put it aside and then come back to it. Then go through a history, an examination and investigations. Examination, obviously, at the moment is compromised because of COVID in a lot of cases. And so medico-legal reporting is more frequently being done via telehealth. And so whilst that, I'll just go back to that for a second. I'll talk a little more to that when I get to that part of the presentation. With regards to, I think I've already spoken about that, the summarising of opinions. It's easy if they're consistent. If there's inconsistencies, then what you guys are not going to be aware of necessarily is the weighting and the value of varying opinions. And that's why if you have somebody who is in working in an area clinically that understands that area, that expertise and that opinion is going to have a greater weighting than a person who doesn't necessarily work in the clinical field. And furthermore, if you have literature quotations, they can be pulled up quite easily to support an opinion, to give it heavier weight. And that's not commonly done, but I think it's a really good thing because if you're in clinical practice, you know exactly what it is that you require to give your opinion more weight. So that depends upon how contentious a particular case is. But I think all of those things are important to know before getting a handle on seeing a patient. This is really telehealth, you might say it's taken away a little bit by eliminating the ability to examine a patient. And I accept that. I think we all have to accept that. It is of the components that comprise a report, the least important of everything is actually the examination. It's certainly better if you have it, but if you don't, it's the least important it would be the first thing you'd say, okay, we can do without the examination. Because the most important thing is the history given by the patient. And so I think there's a lot of similarities between being a lawyer and being a doctor in terms of history taking, because when I get a brief from lawyers, the degree of, and the good ones particularly, I'm sure you're all very good, but the degree of specificity and digging is the key to being successful, in my opinion, in understanding a particular case. So it's, you know, for example, I hurt my knee, you know, on the way to work in a car. So where were you in the car, and how fast were you going, and when you were hit, you know, what was the angle that you were hit? Is there a police report? Show me the angle at which your knee, or can you tell me the angle at which your knee hit the dashboard? And, or, you know, when you stood in the hole, what was the thing that, did you hear a pop or anything? And quite often, and that's the key, because you'll be able to determine whether the known injury is associated with the mechanism of injury, because we know, that's our training, that if someone turns up with a meniscal tear and really they didn't have a twisting injury on a knee that they were squatting on, or if they say, I just banged it on the ground, well, immediately I'm thinking, well, that is not consistent. And until proven otherwise, that didn't happen because of that injury. So, or yeah, that checks out. The behaviour of the patient is, you can still, I've found you can still see that even on a screen, because I think it makes me focus more on the facial characteristics and the behaviour even into a screen, in terms of where the patient's eyes are directed, whether they are very clear and firm on their description. And I've noticed that there's certainly more cues of avoidant behaviour when there might be something that's not quite right, or, you know, the statements of blame is one that really starts to make me interested in whether there are other factors other than the injury that come into play. And having read the brief prior, I then know some of the facts, and I don't say anything other than what I want to know about the injury, and I just allow the patient to expand. And the exclusion of facts is again something that I think is very important, rather than just a difference of facts. So if someone gives a different story or doesn't give you the whole story, then I also start to think that there might be other factors at play. I've had, if I'm seeing someone in person, it's quite easy to gauge the relationship or the dynamics of having the partner present, and the degree of input and the patterns of correction of the statement by the partner is often something that I notice, where a wife or a husband might engage and finish the sentence or say, no, it happened like this. That has a weighting on my opinion and my feel. And I've had episodes of doing telehealth or teleconference reporting where I can see someone looking off screen and hearing whispers and prompts from off stage, so to speak, which are also prompts that I might be dealing with something that's not down the line. So as I said, there are defining symptoms at the time of injury, and then symptoms that are currently present. And so the key thing then is to make a preliminary diagnosis, and oftentimes I'll have patients who present with information and may have even had a report, and there's no specific diagnosis. And one of the things that I find that could be changed, improved, dealt with more succinctly is the process and the time frame between the point of an injury and lodging a claim and having a diagnosis made. There seems to be a pattern whereby there'll be an injury and there will be a period of time which is variable, but can be, I've seen up to 3 years in the extreme, of the triad of physiotherapist, chiropractor, and myotherapist. I'm still not sure what a myotherapist is, treating, in inverted commas, an injury, but there's no diagnosis yet. And that astounds me that that is still being funded and facilitated. And then someone says, well, this has got to finish. And in my point, and I see this hasn't started because we don't know what the diagnosis is. So you've now got a situation where you've got secondary symptoms, and they're both objective symptoms related to the body part, be that a knee or a back or what have you. Then you've got secondary symptoms of having been, limping or what have you. And then you've got this the worst case scenario of the psychological and secondary pain behaviour symptoms, and then you're in a world of trouble, because by that stage the time frame's blown out. It's been legitimised. There's secondary gain. There are other practitioners involved looking at psychology, and the prognosis is going to be very different. So I think the key thing is to get a diagnosis early before treatment is commenced. And treatment, a lot of the time, doesn't need to have a surgeon involved at all, other than to say you don't need a surgeon. And there's a time frame for which this injury will be legitimate, and then after that it won't be legitimate, and that's worth its weight in gold. With regards to past history, with this, as I said, the classification of this, if someone has a pre-existing condition, it might be a previous accident, it might be familial or congenital. So obviously the details that need to be facilitated from a previous injury are when it happened, whether it has any relevance at all to the current injury or condition, and what is the natural history of that condition. So for example, if somebody sustained a severe multi-ligament injury 5-10 years prior to their current condition, they are on a pathway that is going to lead them to a degenerative knee with a poor outcome in the long term, and we know that. So that's where there has to be thought and consideration put into what the apportionment of permanent impairment and so forth might be. Familial conditions are things such as someone that dislocates a kneecap, for example, who has a congenital increased risk of dislocating their kneecap because they're built that way. Patellar malalignment, and there are a number of physical factors which contribute to that. Or somebody who develops back pain and a disc prolapse who has a congenital spondylolisthesis, which is a slippage of one vertebrae on another. And that was part of the slipped disc, or disc protrusion, if you want to call it, is part of the natural history of the condition. So they're the ones where the patient will say, I picked up a box of fruit and I have this pain, and it's found that they've got a degenerative disc or a degenerative knee or what have you, and say, well, you've got a degenerative condition, and say, well, I never had pain before this, now I've got pain, so you know, it's not my fault. And that's a really interesting one, and one that I know where I sit on that, and we'll discuss that further. Congenital are pretty sporadic and rare, and we don't really come across that too often in this context. As I said, the examination is something that, when it's available to be performed, I look for general features. I look for the behaviour of the patient, whether the presence or absence of someone with them, their partner. I look for evidence of previous injury, whether it's consistent with what they've said their previous history is, and probably most telling is, you know, whether the examination findings match up with the history of the injury and what the injury is. But oftentimes the inability to complete the examination because the patient almost won't let you touch them, the inability to complete the examination is an important sign, and to see signs of overstatement of pain, I just stop the examination. And I think that it is relevant that the phrase, the examination was not completed, it was ceased due to the patient stating that it was too painful to continue, is in itself a very strong point to the examination findings that would be in a report. It's normally a negative feature. But in the telehealth era that we are partially in at the moment, the lack of an examination means that you don't have that part to rely on, which I guess we all have to you know, respond to that or adapt to that. So there will be a few signs there that we can't quite use to our to make the assessment. I have on occasion over the last 12 months been provided with video from investigators, and at times that's helpful. It can be cumbersome and laborious and unfruitful, however, if it's something that an insurer wishes to do. So I'm open to comment on that, particularly if you don't get what you believe that you might get out of the video. It ends up being a moot or a null point because you've neither proved nor disproved anything. The other thing that I see is a report which has been compiled. I think all of the previous documentation, medico-legal reports, etc., have been included, which is much appreciated, but there aren't any investigations that have been organised, and it gets back to making a diagnosis to be able to provide the best report in terms of giving you an opinion, giving you a treatment plan, either that there doesn't need to be any treatment or that there does need to be some treatment, and most importantly, a prognostic evaluation in terms of how long it will take for this thing to resolve. Can the patient/client return to their previous occupation, when will that be, and what their percentage impairment is? Because often all of that, you need to have the appropriate investigation. So the earlier the better. Interestingly, there was a trend at one point though, just taking the opposite point of view, that everybody had an MRI, which was a dangerous trend, because if you do an MRI, a lot of the time you'll find something, and if you go by MRI, or usually MRI, and find a diagnosis, that's not find an abnormality. It's not necessarily the diagnosis. It has to correlate with the remainder of the assessment, and so fortunately, I think that common sense has prevailed with that. But I'm certainly not advocating that everybody should have a complete set of investigations right off the bat, because that's not practical, it's expensive and unnecessary. As I said, apportioning impairment, acute versus pre-existing. My response to this is that the previous injury needs to be determined by the examiner as to whether it has been completely resolved, paid out. Did the patient ever return to work? Did they return to their previous level of employment? Or was it unresolved and then another injury has happened? That makes it murkier, and that's where things need to be more decisive on from someone such as myself as to whether the acute injury is a major or a minor contributor. It's minor if the previous condition resolved to conclusion, and the acute injury is clear and significant. It's major if it was previously significant, there was residual PI, ongoing functional impairment, and a known poor natural history and progression, and the acute injury is minor. They're two totally different scenarios. An acute injury, in my assessment, therefore, is grouped as an aggravation, which is a temporary flare-up of a pre-existing condition with no capacity to affect or hasten the onset or deterioration of that person's condition, or their capacity to work or their future earnings. An exacerbation is that plus the initiation of a more rapid progression of the pre-existing condition, which will then alter the natural history of the condition. The specific consequences as a new entity might be finite, or they may contribute to an ongoing incapacity in terms of where capacity is defined as the ability to perform their previous occupation, or the ability to perform any type of occupational or any type of work. And so how long does a aggravation last for? Well, you might say that it's arbitrary and that it's subjective, and, you know, reports, I think one thing that may be frustrating at your end is to have a report where something's judged to be resolved within 6 weeks, and then it blows out to 3 months, and then it's 4 months, and there's this apparent subjectivity and prolonging and further reports, and I would be frustrated if I was an insurer or, you know, trying to resolve the claim. But there is some science. Most of you may be aware that most acute injuries in orthopedics have traditionally worked in blocks of 6 weeks, and that still largely holds true. There's variability, so there's tissue physiology and repair of an injury, and there is return to work and one's previous, you know, lifestyle, activities of daily living, etc. And so there's going to be variability depending upon a particular person's occupational role. But 6 weeks seems to be a reasonable time frame for people to return to most things. If it's a sedentary job, I like to try and advise early introduction of alternative occupational roles, host employers. I think it's not just me, it's well established, as we all know, that the longer someone is out of their previous life, occupationally, daily, recreationally, etc., the more poor the prognosis and the outcome, the more it costs everybody. But tissue recovery, the reason some things take longer is that any part of your body, if it gets injured or it gets inflamed, accumulates fluid and inflammation. And there are documented MRI studies that your circulatory system just cannot take up that fluid for a period of 4 months. It takes 4 months to resolve that situation. So that can sometimes, so depending upon the degree of inflammation and swelling and bruising and so forth, and you can have the same injury between 2 people, and one person will have a little bit of bruising and one person will have a heap of bruising. And so the reason why there is variability, and this makes it difficult at your end to judge or understand why there is variability in opinion, is because of the fact that you say, well, hang on, this guy has got a meniscal cartilage tear of his knee, and he went back to work at 6 weeks. How come this guy's taken 4 months? It's because of this. It's because of the fact that, one, you've got a different physiology in this person. They've received more bruising and swelling at the initial injury, so it's taking them longer to reduce that fluid in the soft tissues and reduce their pain. And then secondly, the personality of the patient and the type of work they do, and then the one that's really difficult, which is the secondary factors, which are the ones that we don't necessarily find out, or that we do find out and we know they're going to be difficult. That is the interpersonal relationships at work and the secondary gain issues. Okay. So I guess if we go to the issues that I'm talking about in acute injury, there's, from a reporting perspective, there is the diagnosis, there's the treatment, there's the best, and from my perspective, I understand that if something has occurred and there needs to be treatment, then there needs to be someone, firstly, there needs to be care of the, or an opinion on the care of the person who has sustained the injury, and what is the best practice management of the individual for that injury. So as a doctor, that's what you do, and that's that can't be neglected. That's paramount to make sure that that occurs. Sometimes you get into the situation whereby if a patient has a ruptured anterior cruciate ligament, and then that hasn't been treated, and then they have an injury at work because of that, and tear their medial meniscus and their lateral meniscus at work, the meniscal tear is accepted by their insurer as a workplace injury, but I can't do an operation or advise that an operation gets done on a meniscus without reconstructing the anterior cruciate ligament, because it will fail. And so the advice might be, take the hit, pay for the anterior cruciate ligament reconstruction, because there will be that's actually what has to be done to make the thing work. And yeah, it's a bigger surgical fee, but you'll actually get the client back to work without any recurrent injury. So there are some curiosities like that that have to be understood, I guess, and accepted. But it gets down to who pays for what, and sometimes that needs to be negotiated, and who's liable. This is one that I struggle with, is people who have a knee problem, for example, and they turn up 12 months later still not having gotten back to their previous employment role, and now they've turned up with a back problem. And I struggle to accept this one, where it's secondary to my knee pain, I couldn't bend, and now I've got a sore back, and now it's in the neck. And recently I had someone that I was reporting on who had an ankle injury, who was claiming for their foot, their ankle, their knee, their hip, and then their spine, all apparently due to the ankle injury. So from my perspective, none of that really, if we're looking for the secondary injury from the primary injury, I find that very hard to get across the line from where I sit. Particularly if there's structural abnormality in other areas of the body, it's almost a dead no every time. So I think that's a broad summary of how I feel about assessments, and an overview of how I approach cases. I'm certainly open for questions if there's anything glaringly obvious that I haven't covered in this time frame.
Thanks again for that, David. I'm sure there are a lot of questions. Feel free to either post them in the chat and I can relay them to David, or just ask away. One here, I won't mention their name unless you'd like me to mention your name. Doctor, what are your thoughts on a subsequent injury to the non-primary injured knee as a result of overcompensating?
Yeah, I don't look favourably on that. This is where you can get into trouble if the longer it goes on, the more traction it's going to get. So if it's 3 years or 2 years, and there hasn't been, what I was saying at the beginning, and there hasn't been a proper diagnosis made, and there's been 2 or 3 years of physiotherapy, myotherapy, chiropractor, pain management specialist, now there's a psychological injury, you're on a hiding to nothing, because it's going to be very hard to turn that person around and they say, now I've got a secondary compensatory injury in the other knee. This thing's just, it's a snowball. And it's, my opinion on it is that and I write it, it's not related. And then the next question I get on the thing is, can this guy go back to work? Well, no, I don't think he can. I say to the patient, can you go, do you feel that you can go back to your job? No way. I haven't worked for 3 years. Why can't you? And then there's this myriad of reasons, and I'm seeing a psychologist and I've got this pain, blah, blah. They will not go back to work. But it's not due to but I say no, the compensatory injury on the other leg is, I don't buy that. But oftentimes it's too late to get a good outcome.
Did that satisfactorily answer your question, Susie, or do you have a follow-up question? Her response was, yes, thanks. Excellent. Any other questions? Feel free to just chime in and ask away. David, do you see anything that's more peculiar to the Queensland environment? I mean, you do work for us in Victoria. as well as Queensland. Do you see any jurisdictional or scheme differences that you'd like to comment on?
Only, yeah, thank you. Only that I believe that and no disrespect to anybody, I believe that the inherent culture of timing of request for an IME is earlier in Queensland, and there's a cost with getting IMEs. And so sometimes on a case-to-case basis, it may be that as an insurer, be that under Q, Cont or work cover, whichever, independent or otherwise, that you feel like you've engaged in a process of spending more money. However, ultimately for me, I believe it's an IME is going to come anyway if the case isn't a simple case. But in Victoria, I find that the time taken to get to that point, due to what appears to be endemically a system of immediately receiving X number of treatments of physiotherapy, myotherapy, and chiropractor as a routine before you see a doctor to get even a referral, to get an investigation, to get a diagnosis, is the main difference.
Yeah. And certainly, I mean, those scheme variations have, look, and it's very contentious. I get it. I mean, iCare pretty much ceased the use of IMEs as part of a strategic change. I'm not saying that was the cause of some of their liability issues, but certainly when you compare Victoria, where within 28 days a liability assessment by a specialist doctor is required, where schemes don't require an IME early on, there seems to be, and please correct me and comment if you feel that I've overstepped the mark here at all, David, but there seems to be a difficulty with those schemes where an IME is not used early on. So Queensland, it's a genuine IME, but Victoria, it's a modified IME because it's about a liability, but it's still by a specialist doctor, not by a GP, which is where they went to in New South Wales when they were saying, well, we'll rely on the GP because they're going to be closer to the treatment side of things. Have you got any sort of reflections on that?
I think, yeah, liability is it's obviously a critical issue if you're paying for it, and so I think that's I think that's a good thing, because it can often, I guess that's what I'm getting at, is that don't start treating something until you either A, know that you're responsible to facilitate it, or B, what it is. So you might be able to, if you have in place an assessment process for liability rather than an IME, I think that's fine, provided that, because that does set up a situation where you're not in what I believe is the most difficult and inappropriate scenario, where you've had a prolonged period of treatment without a diagnosis, or and even worse, I say, I don't even know why you guys were paying for this. Like you could have stopped this before it started. So I don't mind the process of not having an IME. I think that's a reasonable thing in terms of establishing liability. Yeah.
And the IMEs are used a little bit differently in the early stages of the statutory benefit phase of the Queensland scheme, but
yeah, sure. Often it's an early one is a good one because it has a different focus. in terms of what can you expect, what's the appropriate treatment, and the later ones are really more towards how do we extract ourselves from this, what's the prognosis going to be. We've now got an issue with the employer, have we got a permanent impairment assessment coming here, all of those factors which are, they may happen anyway in cases where they're seen early, but I think it's a lot more organised and a lot more predictable for everybody with an early one, which is that or a lot. The liability is different, but I think that you need to get someone who knows the natural history of something and gives you a very good template right from the beginning is the critical thing from my perspective.
So that's a big tick for the Queensland workers' comp scheme from you.
I think that they worked hard on doing that because I recall it might be more than 10 years ago, being one of a panel of people who helped, they wanted to do that. And they looked at their claims, the duration of their claims, and where the money was going. And so they brought together a panel of experts within the various, spinal, upper limb, lower limb. And so this is and this is where the clinical expertise came in. It's like, what normally happens with this stuff? What should we be paying for? What should we be seeing? And then they were able to go away and make processes based on that. And I think that it's a more, I think it's a very economical process that occurs in Queensland. Maybe I see the ones that got away in the Victorian scheme, but I do see more.
You're seeing the 130-week ones as opposed to the liability assessments within 28 days, if I'm not wrong.
Absolutely, yeah. So maybe my opinion is skewed by that. For sure.
Yeah. Okay. Yeah, they're good insights. I mean, in my view, at least, it'd be really helpful if more doctors did interjurisdictional assessments as you do, because you see things in a different way. So personally, I'm very grateful for you doing our Victorian work as well as the Queensland work. Any other questions? We're going to try to wrap up in a few minutes. No comments about the state of origin last night, David. We'll steer away from that.
We'll steer away from that for the Queensland and any New South Wales participants. The Victorian participants are probably not interested in the slightest. Other than to say that the Lions, I think, are running fourth at the moment. So I'll hold on to that one.
Yeah. Well, Queensland have had a good run for a long time. It's nice that you let New South Wales win a game every now and again.
Oh, you've got to credit where credit's due.
Okay, look, I don't think there are any other questions. So we'll give everyone a bit of an early mark. I know you've got a big clinical day on today, David. So many thanks for your time. And Lockie, we won't worry about the MAG and ICS presentation unless you just give us one screenshot there, Lock, about it is important. Actually, this is actually a little bit interesting. David, MAG have another sister company called Insurance and Compensation Services, which is a software and data analytics business. We've run a couple of AI projects recently. One is to do trend analysis across medico-legal reports, where we've identified a number of variables. They're fairly, normal variables: date of birth, date of accident, date of injury, gender, body part, and a few variables. And we've done a little bit of trend analysis across that, so that it can give both insurers a little bit more evidence as to the evidence of medico-legal reports, and saying, well, if these variables are consistent, we now have tens and tens of thousands of medico-legal reports. We're able to do some trend analysis and compare and contrast, which some of the insurers are finding, and the law firms as well, finding quite interesting. And the other piece is across claims, or what insurers refer to as claims leakage, what we would refer to as confusing AMA codes when you're required to put in a quote for surgery or treatment, and the poor insurer, well, at least in New South Wales anyway, is not able to validate those fee codes. We have done a piece of work, and Lockie will talk about it, to help doctors and to help insurers form a view as to the exact and precise value of treatment and surgery. So, Lock, you've got 2 minutes. My apologies.
That's all right. I'll very quickly go through a couple of pieces of work. So, as Mark mentioned, Insurance and Compensation Services is a, software and analytics firm. We deliver a range of software solutions to the insurance and personal injury industry. Two of the key pieces.
Sorry, David, could I get you to unshare your question screen so Locke can do a quick screen share?
Sure.
There we go. If you needed to share your screen, Locke, go ahead.
Yeah, so as I mentioned, we're a software and analytics company, and we work with a range of stakeholders in the personal injury insurance industry. Two key pieces of work we're doing at the moment, as Mark mentioned, is we're working on an AI tool for surgical quotes. So understanding that medical billing and invoice approval for surgery and compensation schemes is a major issue for both insurance agencies and specialists, and looking at some recent judgments by APRA which highlight the need for specialists to have support and for insurers to have support in correctly billing these convoluted and complicated compensation schemes. And so we've got a dual use tool that some of our specialists and stakeholders in the insurance space are using to check surgical quotes against relevant compensation schemes prior to and subsequent to the accepting and verification of those invoices. What we're looking to do is assist our stakeholders in increasing the compliance, decreasing the time required for approval, and really assisting workers in getting back to work sooner by moving their surgeries up. And the second piece of work that we're working on that Mark mentioned is the machine learning for compensation trend analysis, which is using our data analytics team to assist law firm and insurance agencies with a trend analysis of compensation, impairment and treatment decisions across jurisdictions. And that's assisting our stakeholders to support decisions with high quality and compliant data analytics. A couple of other pieces of work that we're doing is we've got some client-specific software, so assisting both law firms, government agencies, insurance companies, and independent specialists with what we call Connect platform, which allows them to transact compliantly and with state-of-the-art data security to book, manage, and bill for medical legal reports and other services. And some other solutions that we're working on at the moment is some open source data analysis projects and some integrated telehealth solutions for our software as well. So back over to you, Mark.
Thanks, Locke. A lot there. Can't believe you actually compressed it into 2 minutes, but well done. If there is any interest, excuse me, that's red wine, not COVID. If there is any interest from anyone, Lockie would be happy to share the details of those AI projects, which are being rapidly taken up across our industry. So, David, thank you very much for your time again today. It's much appreciated. Your insights are really valuable. And sorry I can't hand over the obligatory bottle of wine, but but I will get something to your staff today or over the next few days, because they did provide a lot of IT support for us to get us going today. So thanks very kindly, and look forward to providing access in some other jurisdictions for your medico-legal reports, knowing that you're very busy with your clinical practice, and getting that balance is very difficult.
All right, Mark, thank you very much, and thank you everybody for your time, for listening, and all the best. Talk soon. Bye now.
And last thing, if there are any questions afterwards that you've forgotten about and you wanted to pass on, I'm sure David would be more than happy to respond in the fullness of time.
Sure. Okay, take care, folks. Bye now.
Thanks again. Cheers, David. Bye-bye.